Dr. Sheridan, I'm curious, what's your first memory of nephSAP?
Probably the first time I needed to sit for the boards again. I started looking for sites, and obviously the ASN website was the first place I looked. I have to say, I thought it was fantastic in terms of a review.
And Dr. McGrath, what about you? What was your first memory of nephSAP?
So I did my basic nephrology training back in Ireland, and I certainly used that along with textbooks to try to build my knowledge base. I'd read a topic in a textbook and then go to nephSAP to see where the field is right now and what the recent material is. And as a fellow, I really found it an invaluable source of a lot of material put together in a digestible way.
So I guess, Dr. McGrath, just to continue on that topic, is you advise fellows and let's say people as they're preparing for their first recertification, what advice do you give them in terms of how best to use nephSAP as an educational tool?
Well, I think one of the challenges, both in training and for anyone who's recertifying now, is the sheer volume of research and literature that is being produced. And how do you choose where you're going to start? How do you pick what's important? And I think what I suggest to people is that if you read the relevant nephSAP issue, you can see the areas that are familiar to you and then see where the gaps are in your knowledge. And if you find that there's something you want to learn more about, the references are there. Those are the important studies that have been chosen by an expert in the field. So you know that these are ones that are considered to be of significance. And then you can go back and read in greater depth if that's what your own needs are. So I think it's very useful in both an update, but also in helping you find what those gaps are and how you can fill them in.
And Dr. Sheridan, as you were approaching the opportunity to be responsible, if you will, for nephSAP, what were some of the things that you wanted to make sure that you emphasized?
That it's an update of current literature, which requires setting a framework. We presume a certain degree, amount of information that the clinician already has, but you need to set the stage for for updates in current literature. So for our writers, frame the problem, you frame the current knowledge base, and then you incorporate data from the last 2 years into that knowledge base. And I thought that was my priority because then it does fulfill the requirement to update practicing clinicians. But also for, as Martina suggested, for a fellow or somebody new to the field to get somehow apply the latest information into your own framework of knowledge is important.
And what changes most between when someone completes their fellowship and when they've been in practice for 5 or 10 years? Where do you think the biggest gaps are, sort of thematically?
Current literature. I think there's a gap. There's a great length of time when RCTs are published and practice changes. And the degree to which we can close that gap, to some degree, determines how effective the clinical practice of medicine is. So an example would be the SGLT2 inhibitors. Given, and certainly this could change over time, but given the data we now have, you would want SGLT2 inhibitors to be incorporated into current practice, but with all the caveats about their use that are out there. And it's very hard to keep up with literature for a busy practicing clinician. And there is a natural tendency not to embrace current developments until it's somehow digested and explained by experts. And that's what I think nephSAP attempts to do.
So, Dr. McGrath, as you're thinking about nephSAP trying to address this issue of filling in these gaps, what can we look forward to over the next couple of years?
I think with the new format and the fact that we will have more articles in each issue that are written by specific experts in the field, we will have say, for instance, for our upcoming hypertension issue, we will have an expert in the epidemiology of hypertension write that specific issue. We'll have write that specific article. We will have an expert on the management of hypertension write on that topic. So we will have authors within their specific field who are attending conferences, doing the actual trials, and really thinking very deeply about these questions every day, putting out their summary of the relevant literature that they think clinicians should be applying to their patients on a day-to-day basis. I think that will be the granular impact, I think, of one of the more important granular impacts of the change in nephSAP going forward.
Dr. Sheridan, I'm curious about your background.
I started in basic science. I was studying molecular mechanisms of acute tubular necrosis. And as the mechanisms drew further and further away from the kidney, it became very clear to me I could either be a molecular biologist or a nephrologist, and I really did not want to dispense with clinical nephrology. Around the same time, Up to Date, Bud Rose and Ted Post were looking for a third editor for nephrology section, and it seemed like a perfect way back to clinical nephrology. So I edited Up to Date for about 10 years, and that was great. I just learned so much there, but wanted to get back to the nephrology community, to some degree, the academic nephrology community. And the nephSAP was a absolutely perfect way to contribute more to the community of nephrologists.
And Dr. McGrath, what about your background?
I'm a transplant nephrologist, and similar to Alice, I spent quite a bit of time in the lab. I worked on basic immunology and mechanisms of transplant rejection for a number of years. And then more recently, I've done more training in medical education and started to get more heavily involved in different teaching and educational roles. And as a nephrologist and I suppose an educator, one of the things that I always think about is the volume of research that's out there. How do you try to figure out what's important, and how do you keep up to date? How do you learn? So what drew me to nephSAP is really, I found this as a very exciting opportunity to use my background and my training in education and my own interest in nephrology and staying up to date on everything, and then being involved in something that's so dynamic and changing all the time and moving with the field. The opportunity to share expert knowledge, but really to impact patient care down the line and see our patients do better and disseminate the important knowledge that's out there.
Dr. McGrath, I guess just as a transplant nephrologist, I'm curious as to your thoughts as to a lot is happening there from a policy perspective that may not change necessarily the clinical practice of transplant nephrology, but it's obviously going to change what the field looks like. How does nephSAP address those types of changes?
Well, I think the policy changes that we're seeing coming in transplant are overdue and incredibly welcome, and particularly the immuno bill that's currently working through Congress, I think will be a massive advance for our field and for our patients. One of the major focuses that we have in transplant at the moment is effective use of organs and reducing discard rates for kidneys. And I think nephSAP can also play an important role in that particular issue because, we're starting to do more hepatitis C positive kidneys into hepatitis C negative donors. We're starting to try and increase our use of more higher KDPI kidneys. These are the kidneys that maybe are not of optimal quality, but can get patients off dialysis and give them good quality of life for a few years. So trying to use these kidneys also requires the engagement of the nephrology community. And non-transplant nephrologists also need to understand that these are useful organs that can give good quality of life and survival benefit to their patients. I think nephSAP has an important role to play in that, in terms of educating our community as to these issues and showing people the literature that is behind these advances, and where the field is going, and what we hope to achieve with these particular changes.
Dr. Sheridan, I'm just curious about, as you think through the next couple of years, where do you think some of the flashpoints are going to be in terms of clinical topics, maybe disagreements among experts in a certain area? You know, where can we look forward to maybe some more controversial issues of nephSAP?
Well, I think controversial issues, they're fantastic opportunities, and flashpoints are an excellent opportunity. Where they're going to lie, I'm not sure. I actually think if we do bring in cross-disciplines, we're likely to introduce some controversy. I'm not sure I want to predict where they will be.
Are there topics that nephSAP hasn't in the past covered that you think are opportunities for sort of clinical opportunities for nephrologists that you may either focus an entire issue on or be part of an issue?
Yeah, interstitial nephritis. In the past, we haven't really dedicated entire issues to this. And there are a couple of areas that I strongly think we should cover. An example, Mesoamerican nephropathy, or CKD, of unknown etiology.
As you're organizing the first issue, what should people be looking forward to?
Well, there's a translation of the ACC-AHA guidelines in terms of evaluation and management. The evaluation piece is written by Drs. Townsend and Cohen. The treatment topic is Sandy Taylor, who was very actively involved in formulation of the ACC guidelines. So that's really the mainstay of the issue. We have an epidemiology section written by Priya Vart, who is he's actually a PhD from the Netherlands, trained at Hopkins, I believe, but has done some fantastic work on the social determinants and epidemiologic outcomes of vascular disease, mostly including hypertension. And then the pathophysiology is a tricky one because it is so complex and so far-reaching in hypertension. But that's written by Dr. Joseph Gigliotti from Liberty University in Virginia.
So you've mentioned both hypertension and SGLT2 inhibitors and diabetic kidney disease, and then you've referred to a couple of guidelines. I'm curious, and this is really a question for both of you, given the proliferation of guidelines and the fact that a lot of clinical guidelines don't perfectly align and there's some conflict between and among them, how does nephSAP address those differences of opinion?
Yeah, that may be one of the flashpoints you just mentioned. Dr. Taylor actually did a remarkable job summing up the different guidelines and how ACC-AHA falls into the spectrum. To some degree, we have to be a little bit opinion-based. Certainly, the SPRINT guidelines puts a bit of a heavy emphasis. I mean, ACC relies heavily on the results of SPRINT, and yet it requires expert analysis to distill that for practice. And I think the same is true of how we handle the management of hypertension in nephSAP. I think to some degree we rely on our expert authors to interpret the ACC guidelines for clinical use, particularly in our patient population.
Dr. McGrath, anything to add?
Yeah, I would just add there, some of those conflicting guidelines from different societies also reflect the different perspectives that people are coming from. So if we look at the SGLT2 inhibitors, for instance, the endocrinologists don't see them as very good for the treatment of diabetes necessarily because they don't take down your A1C terribly well, whereas there's a lot of enthusiasm within nephrology and cardiology about these agents for improved outcomes in heart failure and reduced progression of diabetic kidney disease. So I think for many of these guidelines, it does depend a little bit on the perspective of the field where they are seen to apply. And I think that's one of the opportunities for nephSAP as well, to look at and try to see this more globally, look at these from different perspectives and give it in a kind of bite-sized way that nephrologists can see, okay, if I look at this from an endocrine point of view, this is what I would do, but from a kidney specific, this is what is relevant for the patient who's in front of me.
So just as we're wrapping up, I'd be curious to hear from both of you around if you were teaching nephrology either to the medical student, the resident, or to a fellow, and you were using nephSAP as an educational tool, what types of things, how would you use it in this setting?
So we actually use nephSAP as a training tool in our fellowship program at the Brigham. And what we do is we take an issue of nephSAP and we start to work through the questions with the fellows. And as we work through the questions, we go back to the text with, correct and incorrect answers and try to figure out where we got things right and where we got things wrong and how we can learn and what the updates are. So we find it a very, very useful tool to get our fellows discussing cases and then starting to, that are the cases that are presented in the clinical vignettes, and then start to work through the answers and think about where their knowledge is and how they can learn using the issues.
Dr. Sheridan, how about for you? Is there anything in addition that you use nephSAP for, either for fellows, or I'm kind of curious about other trainees?
Yeah, I actually think you could use it almost any stage of training. Certainly, I actually think you could use it in the medical school. HMS starts teaching pathophysiology, physiology and pathophysiology together, and I can easily see nephSAP being used as a springboard for that discussion. But also, at the other end of the spectrum, perhaps the greatest utility is teaching a practicing clinician who is seeing large numbers of patients, has actually very little time to devote to continuing education. And it's imperative that the data are extremely readable and digestible, as Martina said, accurate, and provide a distillation of current literature.
Again, a question for both of you. As you are editing, revising, and then ultimately finalizing different articles within nephSAP, what clearly the piece of being readable from a perspective of a busy clinician, being understandable to someone who's on the sort of in the educational continuum, what else do you look for? What are some of the specifics that you say, yes, this is an excellent contribution in nephSAP?
Transparency, that you state exactly the quality of the data, what is driven by a randomized trial versus what is expert opinion based on clinical experience. Readability and navigability. Readability, some things are better written than others, and the degree to which we can make this readable is good for our audience. Navigability, to some degree, depends on our website. The new website that's now being made available is such an exciting tool to work with because that's obviously a departure from text-based literature. And to some degree, navigability and readability merge together in tools for the present and certainly the future.
Dr.
McGrath, how about from your perspective?
Yeah, I think when I'm reading these articles, I want to echo, I suppose, a lot of what Alice has said. The transparency in terms of how robust and reliable is this particular data that we're quoting, who are the patients that it applies to, so that there's a certain amount of specificity and detail around each of these recommendations and statements. And then also where we do ask some of our authors to add in some basic science and pathophysiology, that's presented in a way that is understandable and relevant to our clinician readers, because if there's a large section of material that goes back to mouse studies that we cannot see applying to our patients, then obviously that's less relevant and more difficult to approach. But if we can use those examples of basic models that really represent well what's happening in our patients, I think those are very powerful learning tools to reinforce what the changes in clinical practice and understanding are.
Well, thank you both for taking the time to have this conversation. I'm really excited about the direction that you're leading nephSAP, and we look forward to the first issue.